Welcome to This Explainer. Okay, today we're diving into something seriously fascinating, how renal scintigraphy acts as a powerful, functional light box for doctors to solve some incredibly complex medical mysteries. If you've ever wondered how clinicians look past the basic, static anatomy of an organ to see how it's actually performing under pressure, well, you are in the right place.
Here is our roadmap for today. We'll start with the functional paradigm, then we'll unmask renovascular hypertension, tackle the mechanical block, evaluate transplant viability, and finally, wrap it all up with a master diagnostic synthesis. Let's get right into it.
All right, part 1, the functional paradigm.
So what exactly is functional renal scintigraphy? Well, by definition, it's an advanced diagnostic imaging technique that evaluates the urodynamics and pathophysiology of the kidneys in real time. And honestly, real time is the absolute key phrase here. It goes way beyond just looking at a static structure. It's a tool that actually lets the medical team watch the kidneys work live. Think of it like this. Standard imaging, like a basic CT or ultrasound, that just gives us the static structure. It's basically a photograph of the plumbing in a house, right? It tells you where the pipes are. But scintigraphy, that actually reveals the urodynamics. It shows us how fluid is actively flowing through those pipes. You literally get to watch form and function working together.
This is a great look at how a typical 25-minute scan unfolds using the radiotracer TC99M Mag 3. We actually track this tracer through 3 distinct phases. First up, you've got this quick 2-minute vascular phase as the blood arrives. Then we see parenchymal transit during the uptake phase. And finally, the drainage phase as the tracer pulls in the renal pelvis and flushes out. It's literally a living process unfolding right there on the screen.
Moving right along to Section 2, Unmasking Renovascular Hypertension.
So here is the crucial question. Out of all the patients presenting with high blood pressure, how do clinicians spot the less than 10% of cases that are actually driven by a hidden mechanical narrowing of the renal artery, what we call renal artery stenosis? It's totally a needle in a haystack situation, right? Because your standard blood pressure tests, they won't show us this underlying cause. Well, it starts by knowing who to test. Doctors are looking for high-risk red flags, things like an abrupt onset of hypertension, especially if the patient is under 30 or over 55, or if their blood pressure just completely ignores a standard 3-drug regimen. But wait, identifying the patient is just step 1. The prep for this scan is intensely strict. The patient has to be really well hydrated, and they have to stop taking diuretics and ACE inhibitors for days beforehand. They even have to pause calcium channel blockers so we don't get unwanted vasodilation. Basically, a patient has to give up half their morning routine just to make sure we get a clean scan.
Now, to force the kidney to kind of show its hand, we use an ACE inhibitor called captopril. See, in a patient with renal artery stenosis, the kidney is basically faking it. It's artificially keeping its filtration rate up by constricting the efferent arteriole using angiotensin II. It's a clever biological trick. But when we administer captopril, we block that angiotensin II. That artificial compensation? Poof, it's gone. The arteriole dilates, and the glomerular filtration rate absolutely plummets. It's a brilliant pharmacological trick that totally unmasks the hidden pathology. To actually visualize this unmasking on screen, we have to use specific radiotracers. The main options are DTPA, which tracks glomerular filtration, or Mag 3, which relies on tubular secretion. Now you'll notice they have slightly different signatures here. DTPA shows a drop in initial uptake, while Mag 3 shows progressive cortical retention. But honestly, the absolute biggest takeaway here is the definitive diagnostic marker. Regardless of which tracer you use, we are looking for a worsening renographic grade post-captopril compared to the patient's baseline. And this is exactly what that worsening looks like. You can literally watch the pathology downgrade on these curves, dropping from a perfectly normal grade 0 all the way down to a flatlined grade 3. We confirm a positive study when the time to peak increases by at least 2 minutes compared to baseline, or, even worse, if the curve just flatlines entirely into a complete absence of function. It is just a brilliantly clear visual of failing urodynamics.
Okay, let's shift gears to Section 3, the mechanical block.
This particular medical mystery happens all the time. A patient gets a CT scan, and it shows a dilated, swollen kidney. But here's the catch. This CT can't tell the radiologist why it's dilated. So our job is to figure out, is this dilated kidney just a stretchy, harmless reservoir from some old issue, or is there a true, dangerous mechanical obstruction blocking the urine that needs surgery right now? To solve this one, we use a totally different kind of chemical provocation. IV Lasix. It's a very powerful diuretic. The goal here is simple but incredibly effective. We want to drastically increase the urine flow rate to try and force a washout of the system. We're basically seeing if the internal plumbing can handle a massive, sudden surge of fluid.
The resulting curves tell the entire story, and honestly, it's pretty elegant. Take a look at curve A. That represents a normal, healthy baseline drainage. Now check out curve B and curve C after the Lasix is injected. Curve B shoots right down, showing a prompt, successful washout. That tells us the kidney was just a sluggish, non-obstructive reservoir. The plumbing is open. But curve C? Yeah, it just keeps climbing. Fluid is pouring in from the diuretic, but it literally has nowhere to go. That is your undeniable proof of a true mechanical block.
Moving into Section 4, Evaluating Transplant Viability.
When it comes to transplants, timing is quite literally everything. Depending on when we do the scan, the potential complications shift dramatically. In those first few minutes to hours post-op, our immediate threats are hyperacute rejection or acute tubular necrosis. Moving into the days to weeks phase, the threat shifts to cell-mediated acute rejection or urine leaks. And then, months to years down the line, chronic allograft nephropathy becomes the primary concern. So knowing when the scan is taking place is just as critical as what we're looking at.
Now, the most common, and frankly, the most stressful dilemma in the days immediately following surgery is distinguishing between two very specific conditions. On one side, we have acute tubular necrosis, or ATN, which generally improves over time. On the other side, we have acute rejection, which is an aggressive, small vessel obliterative disease that rapidly gets worse. The perfusion row here highlights the key indicator. ATN maintains normal perfusion, while acute rejection shows noticeably decreased perfusion. When you put them side by side, the difference is just striking. On the top sequence showing ATN, notice how it maintains good baseline blood flow. The kidney lights up nice and early, even though there's massive cortical retention later on because the tubules aren't working right. But then look at the bottom sequence showing acute rejection. That early perfusion is rapidly deteriorating. You see severely diminished blood flow right from the get-go. And that, right there, is the true hallmark of early rejection.
And finally, Section 5, Master Diagnostic Synthesis.
Bringing everything we've talked about together gives us this fantastic diagnostic cheat sheet. It perfectly links each specific clinical challenge with its unique provocation, the appropriate tracer, and the definitive diagnostic signature. For renovascular hypertension, our tool is captopril to look for a worsening curve. For a dilated kidney, we use IV Lasix to check for a failure to wash out. And for transplants, we use serial monitoring without provocation to watch out for dropping perfusion.
I want to leave you with a golden rule today, something to always keep in the back of your mind when looking at these scans. Scintigraphy does not just map the anatomy, it interrogates the pathophysiology. By using dynamic tools like captopril and Lasix, we aren't just passively looking at the static shape of a kidney, we're actively interrogating how it functions under stress. So the question I'll leave you with is this: how are you going to apply this functional perspective to solve your next difficult clinical case? Thanks so much for joining me for this explainer, and keep asking those great questions.